So SAAD versus BAAD, all diseases SAAD and BAAD, but this is a newer talk for me, so I want to thank Miguel Montero-Baker and Roberto Ferresi for a lot of this content. So what is SAAD and what is BAAD? Basically, SAAD is small artery disease, BAAD is big artery disease. And when you look back, 1985 paper by Michael DeBakey, when he described atherosclerotic plaque, both in the heart and the vascular system, most of the plaque was usually in the article in the proximal, mid-proximal portions of the arterial bed. But again, over time, diabetes, chronic kidney disease, an aging population, the baby boomers, as you go forward and you look at papers in the early 2000s of disease patterns, we started seeing disease move more distally. And as again, with the explosion of diabetes, you see that the diabetic patients are typically, a lot of times, isolated into the tibial vessels, right? And they are a big population of chronic limb ischemia, critical limb ischemia patients. And again, this is a paper, I think it was out of Italy, showing critical limb ischemia in diabetic patients and describing all this tibial disease. But what's absent, even in these papers, is the pedal vessels in the drawings, right? Nobody's really categorized pedal anatomy or risk factors in that sense. So again, with the explosion of diabetic cases, as well as chronic kidney disease in an aging population, we see it all the time, right? Medial arterial calcification, heavy calcium, making access and everything else we do much, much more difficult. Now, medial arterial calcification used to be thought of as a separate non-atherosclerotic entity compared to SAAD. But in the last, I would say 5 years or so, it's really become sort of apparent that this is the same disease process. It just, MAC is, we see it all over, and SAAD is down in the foot. And they're both strong markers for major adverse cardiovascular events and major adverse limb events. And so there is this novel scoring system. It's pretty simple, but it's also very subjective at times. So a SAAD score, but it's difficult because I'll show you, like these cases here, sometimes you can underfill and the vessels look smaller than they really are. Patients have to really stay still. You have to have a good imaging system. There can be spasm, and it depends on where you're injecting from. So the question is it really a desert foot, or is it just underfilled, hibernating vessels? So here's from Dr. Ferresi's article, no SAAD, so again, the distal vessels appearing fairly healthy and still there, as opposed to moderate SAAD, which is a score of 1, and then severe SAAD, score of 2. And again, here's another example, 0, 1, and 2. On the left, it's really what they call, big artery disease, or sometimes big foot artery disease, where the runoff is still fairly reasonable, as you see in those plantar digital vessels. And then again, more diffuse disease, and then absent vessels in the forefoot, leading to presentations like this, where there's no disease almost below, until you get to below ankle. Now, when you look at the examples here of SAAD patients, when you look at a plain radiograph, you see a lot of MAC, right? And you can see the correlation between the small artery disease and what you see when there's no digital subtraction. And there is a pedal MAC score as well. And when you look at, it's a little bit easier to replicate. Inter-observer reproduction is very reliable. And you basically look at these segments and you answer, is there more than 2 centimeters in some of these, or 1 centimeter of calcium? You add it up, and then there's sort of 3 categories of, low MAC, moderate MAC, or severe MAC. Now, what does it mean? So MAC scores and SAAD scores in a study done by Dr. Ferresi showed very good correlation. And so again, led to the conclusion that this is really the same disease. Now, why is it important, and what can we do about it? So it is important because if you look at this odds ratio of having critical limb ischemia, you can see that as you move down, one of the most powerful predictors of critical limb ischemia is any below ankle or arch disease. You can see the odds ratio of over 13. And you see that pedal artery calcification, especially this pedal MAC score, correlates very well with major amputation, better than some of the other things like diabetic status, glass status, and Wi-Fi staging. So what can we do about it? I mean, the good news is, as Dr. I saw Dr. Kuhn is on the agenda for later today, but deep venous arterialization now is an option for these patients that we call no-option patients and desert foot patients. So again, sort of the normal protocol of, is the patient a candidate for revascularization? Is the foot salvageable? And then is there a target vessel? If there's a target vessel, then the patient has other options, right? Like conventional endovascular revascularization, as we saw here, or distal bypass options. But if there's no distal vessel, as that's a good target because of SAAD, then the question is percutaneous DVA, or TADV is the term we're using now, is that feasible? And if so, then that's a potential option for these patients that we typically historically have called no-option patients. All right, so SAAD disease, again, is something that really we're seeing more and more in our daily practices because of the prevalence of diabetes, chronic kidney disease, and an aging population. It's a strong predictor of poor outcomes. These are the patients that we see the white stop signs and these kind of things. MAC and SAAD appear to be the same disease process. And again, luckily, we're getting more options such as DVA for these patients. Thank you.